for the Department of Emergency Medicine at OSU, and I'm helping Dr. Kaufman with this grant.
Welcome. Thank you for being here. Okay, outside of Dr. Kaufman, did we get everybody the opportunity to introduce themselves? Are we missing any?
Hi, this is Annie Marsico. I'm the Director of Local Government and Community Relations for OSU Wexner Medical Center, and I'm on at least until noon. So.
And this is Allie Miller. I also work with Dr. Kaufman's team at Ohio State.
Welcome. Okay, Dr. Kaufman, you want to introduce yourself and maybe just give us, as a starting point, give us a little bit of a flavor for what is happening at OSU in the emergency room around this space.
Sure. So hello, everyone. I actually hate the videos, but I think it's funny that I'm the only one on video today. So I'm Emily Kaufman. I'm an emergency medicine physician. I'm also an internist. I'm dually trained, and I actually work in both capacities at OSU. I would say I lead or run their initiative that's really been in place, well, it's been in place for a couple of years, but really with grant funding since 2018, we have piloted our MAT or MOUD project specifically at OSU East, our community ED on the east side, because we see quite a few patients with all coming substance use disorders, but most notably opioid use disorder. So we have largely grant funded through ODH. Our grant has since lapsed. We have trained a large percentage of providers with their X waiver, so they're able to prescribe, not just within the ED space, but also system-wide. I work very closely with Julie Teeter from Talbot Hall, our inpatient detox unit, and she's been the inspiration for a lot of this work, as well as with our inpatient hospitalist team. I'm a hospitalist myself. I'm actually working on the inpatient side this month, but we have a physician, Peggy Williams, who runs our MAT consult service. And in the ED, over the space since 2018, we've trained about 60 providers. We've had trainings, X-waiver trainings at OSU. We've trained physicians, advanced practice providers, residents, and the hospital medicine division has trained, I think they're probably getting close to like about 40 or so providers. We've trained more than 200 providers across OSU in various other disciplines. We have institutional clinical practice guidelines in place, which are sort of the repository for all folks in our institutional setting to refer to learn about initiation of buprenorphine, specifically both in the emergency department and in the inpatient setting. This is sort of like a standard of care. We have order sets. We have a lot of electronic records integration into our EMR, which is Epic. It's called IHIS within OSU. We now have a screening tool in place for opioid use disorder because we thought we were missing quite a few people, and we're hoping that if this is found to work, that it can be rolled out to primary care setting in hopes of identifying folks. We've been distributing naloxone from the emergency department at East since 2015, but we've really ramped up our efforts. We've now become system-wide at Dawn site since last summer with a lot of the help of Allie Miller, who's on this phone call today. She's our opioid coordinator. So we're now distributing naloxone not only in the emergency department, but also at our community pharmacies, Talbot Hall, and in the inpatient setting. We've been distributing fentanyl test strips since July. We're hoping to roll that out, potentially system-wide eventually. We started integrating peer support in the department with the grant. It's been a little over a year ago. We're hoping to really ramp up that program and get it rolling system-wide. We're doing a lot of really good things. Part of this grant work is to spread the work that we've done to other hospital systems. We were originally going to work with Mount Carmel, specifically Franklinton, but things have somewhat changed a little bit. Grant sort of has a piecemeal program, but there certainly is interest in the community, and looking forward to talking to you guys more. So thanks for having me.
Thank you. I just want to follow up with one additional question. So at OSU East, you guys have implemented a protocol where your emergency room physicians are able to start Suboxone while patients are in the ER setting. Is that correct?
Yes, that's correct. So we are utilizing, you know, the COWS score traditionally. I mean, there's obviously a lot of variability, but we use the COWS score, and then depending on their COWS score, they'll get dosed in the emergency department. If their trajectory is for admission for whatever reason, you know, medical complications of OUD or other issues, it's not time to be dosed in the emergency department, that will carry over. We have like an order set that'll start the dosing on the inpatient side. Or if they're going home, you know, like say, whatever reason they're going home to a stable situation, they're not going directly to treatment for whatever reason, they will go with a bridge prescription. They can't obviously take meds out of the department. Nobody can take any meds out of the department, but they'll be given a prescription. You know, in terms of the uninsured patient, that's always been kind of the tricky one. So we try to link them up with, like, you know, Southeast, like their MAT clinic. We always kind of hope they'll go to Mask or, you know, Maryhaven in some capacity, but patients are obviously different. Some want to pay out of pocket and do like GoodRx, but yes, they either get dosed in the department or they're given a prescription to go, or they go to treatment, you know, depending on their trajectory.
Okay, thanks. And is that happening yet in the other OSU?
Yes, it's available. Yes, it is available. The caveat on the trained providers. So right now, because this pilot really was meant to start at OSU East, just because we see more of the patients. The patients, of course, cross both hospital systems. But in terms of ED volumes and visits, for whatever reason, we just see, it seems like we see more patients with substance use disorder and notably opioid use disorder, and particularly overdoses. So the providers, particularly the attending providers, the physicians, they cross both, you know, campuses. The advanced practice providers, which include the nurse practitioners and the physician assistants, we have essentially like all but one trained. So when you look at the faculty and staff that are work exclusively at the East campus, we have like 95% trained. So in other words, if you're going to go to OSU East on, you know, any day of the week, you should have someone there who's next wave. The main campus it's taken less of a foothold in, and we have some grant sustaining work that we're heading into with ODH, and we're hoping to sort of make that change. So I think there's a lot of different issues at main campus. So one of which is stigma.
Yeah. What percent would you say at the main ER like are trained at this point?
You know, that's a good question. I'd have to go through those numbers. I would say, I don't know, maybe 30%, because we have, you know, counting like the faculty, like the attending physicians, the advanced practice providers, and residents. And some of these residents have now gone on and graduated, but we do have some like third-year residents who are ex-wage who are actually able to write scripts. So, you know, I think to be on the low side, I would say 30%.
Okay, great. And I know that you were hoping to start kind of sharing best practice that you had developed with the other hospital systems and have them begin to implement emergency room initiation of Suboxone.
Right. And they go ahead. Sorry.
Oh, I was just going to say, am I correct then in assuming that no Ohio Health or Mount Carmel ER is doing any Suboxone prescribing?
Well, so I think it's been somewhat piecemeal. So this past summer, there was actually, well, two things. I did a webinar. I don't know, it was like July. A lot of stuff's kind of like lumping together, but I did a webinar that was sponsored through the Central Ohio Hospital Council with Jeff Klingler, and it was specifically on MAT, you know, ED initiation protocols, and this was targeted to Ohio Health, and Mount Carmel was involved. And then we actually had a follow-up sit down meeting with representative partners, who I actually gave copies of our clinical practice guidelines, and I gave them, you know, quite a few resources, with the goal being, with this particular grant, we were going to partner with one particular agency. Now I know that from conversations with Paula Cobelt from, you know, Grant through Ohio Health, I've talked with their addiction, Dr. Shankula, I can't remember his name, but I've talked with their addiction physician at Grant. They were rolling out some type of protocol in November, this past November, because I had talked with them to sort of like help them along. And then I think they have some X-Wave providers in the department. I don't know how well that's going. They have the addiction consult service at Grant. Riverside, obviously all the EDs have access to React. And so in terms of referral patterns, but I don't know what the percentage of X-Wave physicians are through Mid-Ohio Emergency Services is the group that employs the emergency room physicians through Ohio Health. And they all rotate through the various sites, but they were to have like an ED champion at Ohio Health. But I never, like I asked, I said, hey, I can give you resources and help you more. I gave them what I had. And, I never really heard anything more. And then Mount Carmel, it was Mount Carmel Franklinton. We were to partner with them for this particular grant for Deliverable 7, and we had multiple meetings. And then we just found out recently that they backed out. And this may have to do with, with coronavirus, not being able to, maybe being overextended and not having grant support. I don't really know why, but they do have X-Wave providers, and their medical director, Dr. Ryan Kanzler, who runs Mount Carmel Franklinton, was very interested. He's X-Waved. I'm sure he's probably prescribing. He has access to all of our protocols too. There may have been some like institutional restrictions surrounding Suboxone that we had like at OSU. Like when it first started, nobody could prescribe Suboxone like at OSU unless you were X-Wave. Like our policies were actually more restrictive than what the DEA intended. So we had to go through various committees to actually get that like released. So I don't really know what happened with Mount Carmel, to be totally honest. I'd love to hear more. So I think there's a lot of piecemeal work being done. Is that maybe a fair sort of answer to your question?
Okay, thanks.
Yeah. Mm-hmm.
Thank you. Hopefully that was a little informative to people besides me on the call. Certainly that will help Tiffany and I and us here at OACHC kind of understand the lay of the land and maybe work on behalf of this effort to try to reconnect some of the synergy and energy around emergency room initiation of treatment. At this point, I would like to have our health centers take just a couple minutes to do two things. Number one, just briefly give us the status of your current MAT program. And then if you could also talk about any current emergency room referrals that you are intentionally, so not things where you haven't made an intentional coordination, communication, and then developed like a protocol. But if you have an emergency room protocol currently with an ER for referrals, if you could speak to that. So that you don't all jump in at once. I'll try to go in the order Tiffany did. So we'll start with Southeast. Jennifer?
Actually, Sandy just came in, so I'm going to have her jump on here. With regard to our math program, we have a number of...
Sandy, we can't hear you.
With regard to our MAT program, we have a number of providers who are prescribing. We did change our process somewhat because of COVID. We are just initiating groups again using telemedicine. We are continuing to work with React, and React continues to make referrals not only to MASC in Franklin County, but also to the other Suboxone programs, primarily through Mary Haven, some through Southeast, some through providers that aren't part of this project, that are part of the ADAMS system. And I think at some point we may want to grapple with that just a little bit, because you've got two systems working within MAT in this county, both fairly aggressively working with MAT programming. We have met with Grant as an organization with regard to referrals directly from the ED. And we've also met with Ryan Kanzler with regard to direct referrals when he starts Suboxone in the ED. So I don't know if you want any more than that, or if that's suffices as a summary of where we are.
That's great, Sandy. I just want to add one thing. Emily and I have had a recent conversation about a referral process, and she's gotten information from NISA about how to do that in a more intentional way as well from an OSU East or OSU period standpoint. But I wanted to highlight what you said about Adam H system, and I assume you mean the two systems being the Adam H system of MAT treatment capacity versus like our FQHC system. Is that what you were
Yeah,
referring?
yeah, it's kind of like an and we've got two systems of care with very different streams of funding doing similar work. And in my opinion, there's not been a lot of coordination across the two. Southeast is kind of caught in that because we're both.
Right.
And because we run REACT out of our BH program, but we're in the EDs and we're constantly referring, I think that program could benefit by knowing more about what all of the FQs are doing to get them into that referral process as well. So
Okay.
that's something maybe to look at a little bit later when COVID's not such a priority.
Okay, great. I'm parking that on our kind of list of things to consider as part of this project and process. So thank you. Lower Lights?
Yes, this is Karen. We currently provide MAT services to both our Columbus offices and our Marysville offices, and we've got a total of 158 patients. We partner with Freedom Recovery to provide IOP on site here at the Columbus office and starting at Marysville as well within the next couple of weeks, starting through the telehealth. We have been providing MAT services through COVID and also accepting new patients as well. We've got 4 providers who are providing MAT services and have the waivers. So we've done a lot of work with OSU, and Dr. Kaufman, I've been in a couple meetings with you and your staff and just so appreciate that. And we've developed, and we've also met with Dr. Ryan Chancellor at Mount Carmel as well, but have not been able to develop that as far as we have with OSU. So we have actually developed a process, and I work real closely, our team works real closely with Mohammed, who's the medical social worker at OSU. And so we have been receiving patients from the ER, mainly though from the hospital setting, whether they've been there 24 hours or over. And then we've also, so we've been able to treat and be able to schedule those patients within 5 days of their discharge from the hospital so that they do not have any break in their treatment with their Suboxone. And most of the docs at OSU are giving them anywhere from a 5 to a 7 day bridge script to hold them over until our providers can see them. On Tuesdays, we have blocked 3 hours for our one provider for any walk-in patient that's coming from the OSU ERs. And so we've worked with the social workers there to kind of have a statement on the discharge sheet that the patients are getting from the ER, and that they know they have an open appointment, walk-in appointment on Tuesdays at 10 at Lower Lights at the 1160 West Broad site. So to date, we've only received 1 from the ER. Now, that does not mean that there has only been 1 referred. What we're trying to work, and we were starting to do this prior to pre-COVID, is working on some type of system that we would have data knowing how many patients are being referred from ER that maybe never come to our door. So they may change their mind, you know, once they're discharged. So that's a kind of a disconnect there that we want to look at and tighten that up twofold so that we know we have an accurate amount of who is all being referred. And most important, so those individuals don't get lost out there in the system and we have some way to try to continue to contact them. So that's where we are at right now.
And Karen, if I sorry, that's the.
I hear you.
Sorry.
You're good. You're good.
Just to give you, like, you know, like from the ER standpoint, I think we can probably shore up the referral process a little bit. You guys have had like great correspondence with us, and I think we like at least where we are on the east side, sometimes to get folks to you, it may not be their like closest, location or whatnot. But I think we can work up on things to like shore up the referral process and make it a little bit more streamlined. And then also, we're right now trying to find somebody like Mohammed that would be in the emergency department. Well, both, we want one in East too, like ideally, we're just understaffed right now, but also the main campus too. Because I think there's a lot of like referral opportunities that are being missed from the main campus. Because by the time they're inpatient, they're there for other reasons and we got them kind of somewhat captured. But I think we're losing some of those from the ED. So we can work on that, but we've got great.
I think we're at a really good place. And, we started, we were meeting since last fall, but then really put this into action in January. And then of course the COVID, but I think we've done it now enough to know where we need to shore it up. And Muhammad is excellent. If you can kind of like, just kind of mold him and make about 3 or 4 of him and put him in all your ERs, you'll be in great shape.
Thank you, Karen.
Yes.
Yeah, so 2 thoughts that I just want to highlight, and hopefully Tiffany's helping me keep track of these things as I'm saying them, because I'm not doing a very good job. But I think some of you guys are going to be further along, and maybe some of you we're going to find out haven't done anything necessarily super intentional yet. All of that is fine. The whole purpose of this conversation is to kind of assess who's where with any intentional emergency room referral process and linkage. And we certainly want to take the things for those who have done intentional things. We want to take the things that are working. And we also want to identify the things like you just did, Karen, with the not having a loop of knowing who the ER has sent your way. We want to identify those things because at the end of this, we'd really like to see if we can come out with kind of a streamlined, kind of unified process that OSU East can use with all of the FQHCs that are willing to take those referrals and ready to take those referrals. And then we can kind of use that same protocol and process and roll it out to other emergency rooms. So that's the goal that I think we're trying to achieve. So thank you, Lower Lights, for all that you're doing. We're going to move to OSU. Candy, you want to share quickly about where you're at with your MAT program? And
sure. Emily and Mohammed and Julie, we met right in the beginning of COVID, and everything went topsy-turvy, and we moved down the street for a little while to CarePoint East and are seeing patients, but we're coming back home in a week or so. Family practice has a nice algorithm for all of this, but I don't know that and Emily, you can correct me on this if it's just really not gotten going yet with family practice, but we do have a plan or an algorithm on how the referrals will be based. We talked last time when it was Talbot and Dr. Kaufman and I about consulting for the counseling services. That part is kind of missing from our clinic. We have now 5 MAT providers, just number 4 and 5 just finished their education, their XDA. They got their waivers, or should have it within a few days. So we really are ready to rock and roll. It's just a matter of just getting a system in place. And I know, Dana, you've offered to handhold. I know Dr. Kaufman can handhold. I think that's probably just the launching is the scary part, but we are ready to go.
Okay. Thank you. Heard of Ohio?
Hi, can you hear me?
Yes, we can.
Yep. Awesome. Okay. So my name is Sarah. I'm from Heart of Ohio. I'm the Behavioral Health and Social Services Manager here. Dawn Glaze is also on this call. She is our new substance use disorder counselor. So at our agency, our behavioral health department is still relatively new. I started, I believe, in September, and Dawn just started in March, I believe. So it's relatively new. Dawn is seeing patients for individual substance use disorder counseling. I see patients for individual mental health counseling. As far as Matt goes, that's something we're definitely wanting to do more with. Since Dawn's position as substance use disorder counselor is a new position, we're just in the very beginning stages, trying to think of protocols, policies, procedures we can come up with to do Matt. We do have a few providers who do have their data waivers, so they are able to prescribe the medications. When I reached out to some of those providers, they did have some hesitations about prescribing some medications because they just want to have some of those protocols and policies in place. So we're really trying to just kind of wrap our heads around it, what we want it to look like. So a call for help. If anybody here, can kind of help or provide some guidance with, implementing some of those things and just kind of starting from the ground up, because we really are. And right now, as far as the ER referral process, we do not have one. So that is something else that we would like to start doing. And then Dawn is on the call if she has anything she wants to say.
Okay, I'm going to take that as Dawn. You did a great job summarizing things. Thank you. That was very informative. And certainly Tiffany and I can loop back around with you guys individually to try to see if we can provide some of those documents and pieces for you so that you don't have to reinvent things.
Can I ask?
That would be great. We're not really sure to start. Thank you.
Where are you guys located? I'm sorry, I'm not familiar. What part of town are you guys
That's fine.
Sorry?
We have two main locations. One's at Capitol Park, so that's going to be on the north side, close to Westerville. It's on the corner of Ennis Road and State Street. And then we also have a location out in Whitehall that's on the corner of Hamilton and Main. So in that little Kroger shopping plaza where there's also a Rose's. We also just opened up a federally qualified healthcare center inside the Whitehall Yearling High School. That's currently not open. We're going to reopen it, I think, the end of this month just because of COVID-19 concerns. And then I think we're also working on a satellite location at Mount Carmel.
Which Mount Carmel?
I believe it's Mount Carmel East. And I don't think we're going to have like all of our services there. I think it may just be more focused on women's care, I want to say. So I don't think we'll have like behavioral health and all that.
Great. Faith Mission.
Hello. So our MAP program is fairly new. We've been doing it for over a year now. I feel like we're in a really good, comfortable place of our processes, policies, procedures. We currently, all of our providers do have their waiver, and so they are actively prescribing Suboxone and Vivitrol to patients on an outpatient basis. As far as we're currently accepting new patients, we're utilizing telehealth. We are doing some in-person visits if necessary with new MAT patients. They're seeing the nurse if they need to do a urine drug screen or something of that nature. And so we are accepting new folks. We recently have kind of beefed up our behavioral health department. We've hired a recovery counselor and another behavioral health worker. She's the manager of that department. So we hope to just continue to increase our capacity to provide behavioral health services on an outpatient basis. As of right now, we have, community referral partners that we work with and we do outreach to. We do not have any formal agreements with or referral processes with any of the hospital systems. I don't believe we've received any referrals directly from the emergency department up to date, but we have received some referrals and calls from the inpatient standpoint. So we're definitely wanting to identify a way to strategize and have a more formal arrangement with the local health, local hospitals, specifically grants. There's been some conversation. We work with them in some other capacities, and so conversation around developing that type of system with them, since we're in such close proximity. We do have 2 peer support community health workers that are contracted with Mount Carmel Health Systems. They are in the emergency departments. They are linking directly with individuals that come in with substance use disorders, trying to get them in treatment, you know, talking to them, assessing their level of readiness, and then making those referrals. I think due to the proximity of Faith Mission Health Center and Mount Carmel emergency departments, that creates a bit of a barrier as far as where the patients that come into those EDs are, either where they're housed or where they primarily reside, and the convenience of coming to the health center at Faith Mission for their opioid MAT treatment, as opposed to another office that may be closer to them. So that's presented a challenge, but we continue to work and strategize, and if it makes sense for the patient, that's when those referrals are made directly to us by our community health workers for MAT treatment. So other than that, that's kind of where we're at with our MAT services at this point.
Great, thanks, Audrey. I'm gonna just speak what I heard that maybe needs to go on our list for additional worker thought. Sandy had mentioned the REACT team and the usefulness of them knowing and having some coordinated picture of what is available through all the FQHCs. It sounds like for your peer supporters that are in the Mount Carmel hospitals, right, that would be beneficial for them as well.
And Dana, just sorry, and I was trying to speak to everything that came to mind as far as our MAT efforts. We did have a meeting with REACT with some of the workers there that are on that team. They came to the health center. We gave them information about our program, got that out to our MAT staff and behavioral health staff. And so the community health worker peer supporters are aware of that, of REACT. I don't believe we received very many referrals directly from that team, though.
Okay, thanks. Okay, so I'd like to toss it back to Dr. Kaufman for a minute to speak from the standpoint of the emergency room perspective of working with a patient who isn't going to need to go inpatient and isn't selecting to go to detox or a treatment facility. So you are going to put them on a bridge script and send them home. I want you to speak to what are the logistical items that we need to think through or be aware of, or what are the current barriers, however that's easiest for you to kind of help us as we start to think about a best practice for the referral process.
Yeah, and this is where it gets, unfortunately a lot more ambiguous. So a lot of it comes down to, at least the patients that for the most part come to our emergency department, a lot of it comes down to transportation, finances, insurance. There's always extenuating circumstances. I mean, there are folks who you want to link or, potentially get into an inpatient program, but then you're worried about their first meeting with their parole officer or, childcare issues. There always seems to be something extenuating. So transportation to a certain degree, that's why a lot of times we try to keep folks on bus lines or, within walking distance, to be honest. We send a lot of our folks to places on the east side because they know it, they can get there. Certainly getting people enrolled, like to even get them to start to get enrolled in Medicaid is a big deal. We have in the emergency department during limited hours, and I'm talking pre-COVID because I'm not sure if they're doing any of this now, to be honest, but we had one particular individual from financial aid who would come and during certain hours of the day would potentially, while people are sitting in the department, getting their work up, would, work towards getting them potentially enrolled or at least starting that process. So we need more of that so we can qualify for more services. Getting the prescriptions filled. I mean, I think we've come a long way from when we first started doing this and having, patients would tell us, like, don't send this to so-and-so pharmacy because they're going to give me a really hard time about filling my Suboxone. We did a lot of like internal sending to our own pharmacies to assure that the medications would get filled. So, I mean, I think that's gotten a lot better. There were a lot of these like prior authorizations that have been removed, fortunately. So if, somebody is motivated to fill it and actually, initiate or their treatment, they'll do it as long as they, of course, have resources. There are a few health centers, at least I know, like on Broad Street, there's one. I don't think they're an FQHC, otherwise they probably would be here too. They have their own pharmacy, and I think they did dispense, but, and I know a lot of our patients go there, because that's the trickiest one, is like sometimes people just want to go and they want to get a dose, and then they want to go on about their like regular day. So that can be challenging. I think the hardest part is, so we have a certain trajectory for those, I want treatment now. And everybody always, a lot of people say they want inpatient or they want residential, ultimately is what they want. They want to be like stabilized. And so for us, that pathway is much narrower. We try to send patients to Talbot Hall. Obviously, we're right there in proximity. We have a very good relationship with them. Or we're going typically like Mass. I mean, occasionally with dual diagnosis, we're going to the Springs, Sun Behavioral, there again, depending on their insurance. So in terms of outpatient providers, my experience with React, and we've been working with React since the beginning, they're a great resource to have, and we're looking to get them back in the department, but they're a little bit different now than they were when they first started. So because we have maybe some more resources in our particular department, we have most of our social workers are very like substance use disorder invested. So they will work towards finding treatment options. We're lucky to have, Thrive in the department. Evan Rooney is our lead. They have a repository of resources, and we're trying, actually one of my goals is to work on all these like treatment referral patterns and put it in like a centralized location. So when we don't have a social worker or a peer supporter or a case manager isn't there, because we don't have case managers on the weekend, somebody else can look at this and say, hey, let me get you to this particular place. So we, through various community building, community relationships, we have an easy referral to, like say, Community for New Directions. They are on the east side. Most of the patients know it. It's called the Neighborhood House. People can get there. It's on the bus line. She has a very welcoming policy, and we'll take patients. It usually just involves a phone call. What is difficult, and I appreciate this meeting because I think we're going to work on this, is, Lower Lights has a set kind of walk-in day. That's great. We can establish that. But there's been a lot of like shifting of days and availability and times and who takes what, insurance. And so when React comes into the department, if somebody wants to go to Mask and they're accepted, there's not other criteria that would preclude them from going to Mask, that's great. They can get to treatment during certain hours of the day. If they're not going to treatment, they're typically left with a card with a phone number. And I know that they follow up. I mean, they typically will follow up the next day. And I think that's when that community referral pattern is going on. But when the patient's leaving the department, they're pretty much given the resources we have them. If they're given a bridge script, we're trying to identify them usually with Talbot Hall, Community for Directions. We've kept that referral pattern kind of small to the agencies that we know well, we communicate with. And so I think that's an area that we need to have a better breadth on, because that's, I'm the one writing the script, but I'm not the one making the appointment. That's when I rely on my social workers and, peer support folks, or maybe my case manager, depending on what that referral pattern is going to be. If it's within OSU, like Candy's talking about with Total Health and Wellness, that's great. I mean, I have control over that. I can make a internal order. It's called an ambulatory referral, and my case manager will get that. And I know at least that appointment will be made, and they will have that appointment when they leave the department. But when anybody's leaving the department after hours, they're not getting, they will not have an appointment written down unless we know they're going to like a walk-in appointment too. So I think that's an area we need to really tighten.
Yeah, I would like to just talk about the problem that lack of a clear system creates for you, and then I think ultimately for the patients, is you don't know how long to write that bridge script for. And my experience has been working at Mary Haven and elsewhere that those patients are most likely to keep that first like linked treatment appointment coming out of even a situation of detox or residential at Mary Haven. They're most likely to keep it if the bridge script is matched up perfectly to when that appointment date and time is. That is our best hope of having the highest percentage of linkages. And so I would just highlight the need or the desire for us to think about a protocol and a system that will allow that bridge script to be written specific to the appointment date and time.
To be honest, like when we first started doing this, like the original protocol that would come out would be these like 24, you're giving them basically a day's worth of Suboxone, which clearly that was unrealistic, particularly people coming in on the weekends, whatnot. React, like, a few years ago, it used to be when they left, they'd have an appointment at like the Southeast MAT clinic, like they'd give an appointment, they'd write it down. That seems to have gone away a little bit, and I think we're working towards, like, for, at least specifically for the Southeast MAT clinic, like shore that up, which I think would be a good thing. But so it was like 24, and then it was like 72 hours. And then it was the reality of the situation is we know that people weren't making these appointments or things were happening, cars break. I mean, who knows, like we're not initiating, we're not, whatever. So I think we found for those of us who prescribe, at least in this particular setting, you see there's a little more control over on the inpatient side because they're going to leave with an appointment now that we have substance use social workers who have the time to like call and can allow callbacks and whatnot too. But I think anymore, for those of us who've been doing this a little while, we tend to give them a longer script if we don't have that set appointment. So it's not uncommon for me to give people like a week script, depending on what the circumstance is. So, but I wholeheartedly agree with you. I wholeheartedly agree with you. Like getting an appointment is what we would do.
Which is great, and would certainly want you guys on your end to be erring on that side with unclear appointments or follow-up perspective. But what tends to happen then on our end is those patients tend to not show up, and then they may follow up, but they've then been off their medication and we have to reinitiate. So just trying to keep that medication going consistently and get them to actually show up for that initial MAT program appointment. Okay, so I know that we have about roughly 10 minutes left. So I think at this point, I'd like to switch and open the floor for anybody to say kind of what they think the most logical next steps are from the conversation today and the information we've been able to share.
This is Audrey from the Health Center. I think from my perspective for our program, I would really like to, and I know that's the overall goal, but is to create these referral systems that are more structured or more formal. But for us, I think it's just a matter of getting linked with the appropriate people now. I was trying to keep get contact information and linked with the appropriate people or social workers within the emergency departments to where we can create and develop a relationship. Our staff can become familiar and they can become familiar with us, even if there's not a formal agreement. I think from us, we're a newer program. I just want your emergency departments, OSU, whoever, to know that we have those services available, we have capacity, and we can take people and are willing to take people. So I would really like to just start out with identifying key contacts or social workers within the EDs to link up with.
Okay, great. Anybody else sitting with any burning things? Okay,
This is Jen from OSU, and I don't work clinically, and I appreciate all the work that all of you guys are doing. From a logistics standpoint, I think Audrey kind of touched on it, is they have capacity. And I think at 2 in the morning when somebody is trying to help with a referral, knowing who has capacity and when is probably the most important thing in emergency rooms. Most of these patients don't come in at times when I would assume most of your resources are open. So figuring out that link of when everybody else is closed, but this patient needs a plan would
Absolutely.
be probably one of the priorities to think about.
Great. That's a really, sorry, Jen, that's a really good point. And I spared you guys that, but yes, it's inevitable. Every night shift, someone comes in and we have nowhere to send them. And I'd love to say that we can hold patients in the emergency department until they can walk to treatment, but I have battled that a little bit in our department. So that having a good communication process and ability to refer that person and tell them where they're going, because they're not going to know where they're going if they're going home at 3 in the morning and they have a safe place to go. That's a really important point. So.
Okay, so I'm going to process what I'm hearing in my brain so far, and you guys correct me if you think it's off base. It sounds like we have the need and desire to create a list of emergency room social worker contacts, and I would make it a list where those are kind of side by side with the correct health center MAT program contact, so that both parties kind of know that communication loop and option. And then I think as we start to try to create a more uniform, streamlined referral process, I think it is going to be critical for us to be able to kind of define how each health center's capacity is and how those appointments and or capacity are going to be made available. So maybe on the health center side, you guys can give that some thought, and we can circle back around with that. And remember, as you're thinking about that, is there a way that it would work within your system for the emergency room? And over time, remember, this could be multiple emergency rooms, to be able to actually identify the appointment time and date that they are selecting from you to give the patient. And then this call's been super helpful and super informative, I think, on our OACHC side. So there are a handful of other kind of things that you highlighted as potential things to work on that we will put on our short list as well. That, you know, the Atom H versus the FQHC system, the peers and React, and how do we connect some of those dots, which will also help solidify these processes. Tiffany, do you, or Ashley, who I think got on the call, do you have any questions, concerns, or things that we need to try to still accomplish with our last 5 minutes?
This is Tiffany. I was just wondering if we want to have any sort of recurrent meeting with this group, or maybe just a listserv or email communication to continue the conversation, or sort of what we want to do with that piece.
Great point. What do you guys think or want?
And what's your ability, I guess, to...
I would be in agreement with having some type of follow-up.
Yeah,
that would be great for lower lights as well.
Sarah from Heart of Ohio, I think having follow-up would be helpful, especially for us since we're in the beginning stages of things.
Southeast agrees. We'd love to be involved in some follow-up.
Great. Dr. Kaufman, from your team's perspective, is that doable?
Yeah, no, that's fine. There may be, sometimes I can't come to all meetings, but yes, absolutely. And I would involve my, ED social work too, because they're integral to this process. I think one was supposed to be here and I'm guessing something came up. So, but yes, absolutely.
And what do we think is a comfortable kind of pace or interval? Do we want to try to do something on a monthly basis for a little bit? Or is that too much?
For this cycle of the grant, so we're still in year 1, that would leave us 3 more months to meet. So I don't know if that's if that works for people. I'd be happy to set it up.
Would the group be comfortable with us trying to identify 3 more monthly meetings? We all just kind of make it if we can make it. And OACHC will commit to making sure that it goes out to everyone so that whether you make it or not, you can kind of stay in the loop and we can communicate by email as well. Would that work?
That sounds good. Yes.
Yes, that would work.
Okay, sounds like a great plan. Anybody have?
Dana, can I ask a
Sure.
few more things just before we get off the call, just because I'm interested in a little bit more for other projects that we're working on. But for all of you who are working on this, what kind of access do you guys use for ORs when you have your MAT providers that are working? Are they directly logging into the OR system to find out opioid prescriptions for those patients, or do you have some other plan?
So
Or is it something I could follow up with you guys individually?
Yeah, this is Dana and Tiffany on the OACHC side. That's actually another strategy that we're involved in on this Franklin County Public Health grant. And I would just say what we understand so far from the health centers who we've queried individually, the majority have ORs integrated directly into their EHR, so the provider does not have to leave EHR to do that. And most are doing the practice of checking ORs with a controlled substance and or Suboxone prescription.
Thanks. Yeah, we're working on the same project, and I appreciate it.
But we can bring that up at one of our monthly connections with everybody.
We would love to circle back because I think you guys maybe have developed some training. Is that right?
Well, I think that's our other deliverable 4 that we're working on together. I don't know about the training part, but we have that integration within our EMR that we can. We have folks that can help with that, but the training part, I think we need to talk about that another time.
Sure. Yeah. Maybe you and I can have a sidebar on that one.
Okay. All right. Sounds good.
All right.
This is Lindsay.
Oh, go ahead.
Okay. This is Lindsay Roenhauser from Franklin County Public Health, and I jumped on halfway through, but I took down some notes, and I just want to thank everyone on behalf of Franklin County Public Health for participating in this project, and I think it's really important, and even just with 30 minutes, I love the conversation, so thank you all.
Great, thank you. Okay, well, thank you, everybody. I think it was a great initial conversation, and I'm super excited with the work everyone's doing and the potential that we have to do something collaborative and move things forward for Franklin County. And more importantly, for the patients that need these connections and need access to treatment.
And have a great Tiffany, I did record, so I'll just send it to everybody because I know folks were probably trying to scribble down notes, but I just recorded for the purpose of minutes. So I will send those out to all of you and get next meetings on the books.
Great.
Thank you.
Thanks, everybody. Have a wonderful weekend and stay healthy and safe.
Thank you.
Thanks, Dana.
Thank you.
Bye-bye.
Thank you. Bye-bye.